Hi, I'm Dr. Lisa Straight of the University of Washington School of Medicine in Seattle, Washington. I'm here with Dayna Early of Washington University School of Medicine in St. Louis, Missouri, and we're going to discuss a paper in which she's the author of called Patient Preferences of a Resect and Discard Paradigm. I just wondered if you could give us a brief overview of the paradigm and your motivation for studying patient preferences.
So the resect and discard paradigm suggests that we can remove diminutive polyps and discard them rather than send them for histopathology. And one of the main advantages of that is that you save the cost of histopathology, which if you apply it in a large group of patients, nationwide, it's a huge cost savings. But no one had really looked at whether this is something that patients are comfortable with, because the risk of cancer in a diminutive polyp is extremely low, but it's not zero. So we thought it was worthwhile to look at patients' attitudes towards a resect and discard paradigm, because we feel like if it is adopted across the nation, that patients may be uncomfortable with this notion of not having their polyp examined.
Thank you. And just again, briefly, your methods in assessing patient preferences?
So we performed a survey study, and we provided this to outpatients who were undergoing screening or surveillance colonoscopy. And we basically provided them a hypothetical situation in which they would have a diminutive polyp identified, and it would be resected and discarded. And we basically asked them, would you be willing to pay for the histopathology cost so that you would know if there was cancer in the polyp? And we gave them a figure to kind of compare. The risk of having cancer in a polyp is about the same as the risk of being struck by lightning, but it's significantly less than dying in a car crash or having identical twins, so things that we thought people could relate to. And then we asked them their willingness to pay. And then we also asked some other factors that might be associated with their willingness to pay, such as the cost and their comfort with the doctor performing the colonoscopy and the risk of having cancer in a polyp.
And what were your major findings?
Well, not surprisingly to me, almost 3/4 of the patients were willing to pay to have their polyp examined for histopathology. And we found that for some factors, the cost was actually a significant factor for patients who were not willing to pay, suggesting that if there was a lower cost, maybe more people would be willing to pay. And the risk of having cancer was a significant factor for individuals that were willing to pay. Other factors that turned out to be significant in the multivariate analysis were female age and higher income, which I think is not surprising.
Mm-hmm. And I noticed that perceived risk or family history of colon cancer was a less strong predictor than income, for example. What do you think is driving that in the analysis? We
were surprised by that as well. I think that patients as well as doctors don't completely understand the impact of family history on the risk of colon cancer, and I think that might have come into play in terms of how patients answer that on the survey.
Mm-hmm. And it may be difficult to, although you had a nice figure, to demonstrate to patients the risk of cancer in a small
Mm-hmm.
polyp. Do you think that has implications for this being rolled out into practice, being able to discuss risk with patients in a meaningful way?
In my view, if the resect and discard paradigm is adopted nationally, I think we have to have that discussion with patients in the spirit of full disclosure. I think patients need to be partners in their health care, and I think they need to understand. I think there's an assumption that polyps get sent for histopathology. As you know, many patients ask that right after the procedure, "Oh, you're going to test my polyp, aren't you?" So I think that's a general assumption, and I think if we're going to veer away from that, I think patients need to be aware of that and be able to have a choice of having their polyp analyzed if they want to.
And again, one of the primary findings was that cost is important to patients. You had a cost threshold of $150, but at my hospital, I think that seems low, and many times we send more than one bottle of pathology. How do you think that would impact?
That's true. We kind of had to identify some cutoff point for the purposes of the study. $150 is roughly what it costs to have a jar analyzed at our hospital. But because cost was the significant factor for those that weren't willing to pay, one could assume that if you lower the cost even further, that many more patients, so more than 75%, might be willing to pay. I'm not sure if that's worth looking at because it may not be a realistic situation, but that would be interesting to learn.
Thank you very much. Do you have future plans to study more on patient preferences in this paradigm?
I think that we will, particularly because I have the sense that this really is gaining some momentum nationwide, and I think we really have to understand how patient preferences play into this.
Thank you. We look forward to that work.